The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. Here, we bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. My name is Shaleen Sathe, and I'm currently one of the general surgery residents, and I will be your host for this episode. On this episode, we are thrilled to have Dr. Panni here to review the management of all things stomach.
Hi, I'm Roheena Panni, and I'm one of the surgical oncologists and HPB surgeons at WashU. Thank you for having me.
Thank you, Dr. Panni, for being here today and offering us your expertise on this topic. On this episode, we will be covering all things related to the stomach, including a brief introduction, as well as an array of both benign and malignant diseases. We will focus on the most high-yield topics from the chapter today. Let's jump into our first case scenario to guide our discussion. A 58-year-old patient with poorly controlled type 2 diabetes presents to your office complaining of postprandial fullness, bloating, and nausea and vomiting. What are some of the things you would like to know on history and physical, and is there any additional imaging that you would like?
I usually start with a comprehensive history and physical examination, as various conditions can manifest with similar symptoms that can range from malignant processes to benign processes. In this specific case, considering the patient's history of poorly controlled diabetes, a concern would be gastroparesis. It's important to cover family history, environmental exposures, prior surgeries, for example, foregut or bariatric procedures, or any other upper GI procedures, and not to mention history of smoking and alcohol use is also very important. Most of the workup involves excluding any mechanical obstruction, and EGD is one of the common procedures that we utilize in addition to an upper GI gastrointestinal series to rule out obstruction. And in order to make a diagnosis of gastroparesis, it's important to utilize nuclear medicine scan, which is a gastric emptying study, to make the diagnosis.
The patient undergoes extensive workup and is ultimately diagnosed with gastroparesis. How would you manage this condition?
That's very important because typically, as when you see these patients, they're mostly seen in the surgical clinic, but there's a lot that goes into medical management and dietary modification prior to that. Patients who are diabetics, the most important goal is better glycemic control, ideally in conjunction with endocrinology. They see a dietitian and undergo dietary modifications, and we put them on medical therapies like Reglan. When we see the patients in our surgical clinics, typically the options are reserved for refractory cases, and the choice of procedure depends on the patient's comorbidities, how robust they are, and what were the underlying risk factors. Gastric stimulator has shown a success, and it's a procedure that's performed by a lot of MIS surgeons here for select patients. Pyloromyotomy or pyloroplasty is another option. And depending on the patient's presentation, sometimes a venting gastrostomy can be considered for palliation of their symptoms.
Great. Now let's move on to our next case scenario and discussion. A 72-year-old female presents to the emergency department with complaints of 1 day of coffee ground emesis. What is a differential diagnosis for an upper GI bleed?
That's a very important scenario and unfortunately a common one. And it's important to keep a broad differential in mind when gathering all the information to guide your management. Some of the most common causes of upper GI bleed include peptic ulcer disease, esophagitis, gastritis, and it's important to capture all the relevant information that can help you confirm the diagnosis, for example, NSAID use, prior history of gastric ulcers, any prior endoscopies. It is important to ask questions related to hepatitis and liver cirrhosis just to know whether there could be any concerns for portal hypertension. And when you get the labs, evaluate those for platelet count and look for any varices. Some of the less common scenarios, which we sometimes see, include patients who present with chest pain and upper severe epigastric pain with bleeding, and those are related to traumatic lesions, including Mallory-Weiss tears or sometimes Cameron ulcers.
How would you work up this patient?
Yeah, so it's important that whenever someone presents in the ER, overall evaluation, an assessment of hemodynamic stability should be performed first. But for discussion purposes, we will go through various aspects of management as it's discussed in the chapter. But it's very important to remember the management starts as soon as the patient is evaluated in the ER. So starting with an IV access, monitoring vital signs, initiating resuscitation, obtaining labs, including CBC, BMP, liver function tests, and a type and cross. It all happens at the same time. In order to confirm the diagnosis, once you know that the patient is hemodynamically stable, we usually proceed with an upper endoscopy to confirm the diagnosis. And I want to emphasize with the developments we have seen in the GI field, it's not just diagnostic modality, but largely therapeutic in the cases of upper GI bleeding. In addition to controlling the bleed, they can help confirm any underlying infectious or malignant processes that led to bleeding, like H. pylori or gastric cancer, and we'll talk more about that in a second.
How does the Forrest classification help with clinical management?
Yeah, so Forrest classification has evolved a lot. It is a widely used classification system for ulcer-related upper GI bleed, and is used to diagnose and predict the prognosis and whether the patient will need another endoscopic intervention. So most importantly, the classification categorizes the bleeding event and predicts the risk for rebleed. So the way I want to stratify it for residents is in the setting of an acute bleed, active spurting or oozing are the terms that are used, which basically predict a high risk for rebleeding after the endoscopic intervention and control. Terms like non-bleeding visible vessel or adherent clot or flat pigmented spots are used to describe signs of a recent bleed with the risk of rebleed that can be anywhere between 10 to 50% based on these findings. And a clean-based ulcer without any active bleed typically has the minimal risk of rebleeding. So it's important to look for those terms when you see the endoscopy report or the patient is undergoing an intervention and kind of triage where they should be, whether they should go to the ICU or should be sent to the floor, and how closely do they need to be monitored.
So this patient undergoes the appropriate workup, everything that you mentioned, and is found to have a Forrest 2B ulcer. How should this be managed?
So for patients who have had a recent bleed that's not actively bleeding during the endoscopy, there are several interventions that they can perform, including thermal coagulation, hemoclips, or sclerosing agents that prevents the rebleeding. At this time, biopsies are also performed, as I previously mentioned, to confirm additional diagnoses that could have led to an ulcer-related bleed like H. pylori. Patients, most of the times, will be started on a PPI right away, and if the diagnosis of an H. pylori is confirmed, then they need that triple therapy, which is PPI in combination with clarithromycin or plus amoxicillin or metronidazole for 10 to 14 days.
If the patient has a second episode of rebleeding, how should this be managed?
Yeah, it's important to emphasize that after the first bleeding event, they should be carefully monitored and their labs should be closely evaluated to make sure they don't end up having a rebleed or the NG output does not look bloody again. In the setting of an ongoing hemorrhage, especially the rebleeds, we still prefer to go back endoscopically and perform a repeat endoscopy and see if that can be controlled that way. But there are some situations where surgery has to be considered. And those are mostly repeated episodes of bleeding, which lead to continued hemodynamic instability, ongoing transfusion requirements, and more than one unsuccessful attempts of endoscopic intervention. For bleeding duodenal ulcers, the concern is usually ulcer erosion into the gastroduodenal artery. Therefore, a duodenotomy and 3-point ligation of the bleeding vessel is the classic teaching. And it depends on the patient's hemodynamic stability intra-op, whether a simultaneous acid reduction procedure should be considered, especially for patients who have failed medical therapy, or should they be closely monitored and reevaluated for those procedures down the road.
Great. Scenario change now. If someone with known ulcer disease presents with perforation, how would you manage their problem at this point?
This is actually a very different situation then, because they are perforated, so surgical intervention becomes the first intervention. When patients present with a perforation, most of the time they are hemodynamically unstable with peritonitis, and you have to take them to the operating room urgently. Just gathering as much information as you can to confirm they had prior ulcer, and if you can get some more information from prior endoscopies is useful, but a lot of times we don't have that when we're in the operating room. And the surgical repair typically involves washout and primary repair of the perforation, either with a gram patch and biopsies to confirm the diagnosis. Again, similar situation as the first bleeding scenario, you have to go by evaluating patients' hemodynamic stability to determine whether entrectomy, vagotomy, or any of those acid reduction procedures can be performed at the same time.
And what is the longer-term management of an ulcer?
Well, long-term, these patients stay on PPIs and have to be carefully monitored and evaluated by a GI team to confirm the ulcer has healed with the medical management. And smoking cessation is another factor we should emphasize a lot and counsel patients to minimize their risk for having a recurrent ulcer.
That concludes our discussion of various benign diseases. Now let's jump into our next scenario. An 81-year-old male presents to your clinic with nonspecific abdominal pain, weight loss, and fatigue. He appears cachectic on exam, and given his overall picture, you're concerned about malignancy. What are some of the risk factors for gastric adenocarcinoma?
This is a classic scenario where suspicion for an underlying malignancy should be very high, given the unexpected weight loss, early satiety, fatigue, and cachexia. Some of the common risk factors for malignancy or gastric cancer include family history, male gender, low socioeconomic status, diet high in nitrates. H. pylori has a strong correlation with developing malignancy in the future, and CDH1 mutation also predisposes patients to hereditary diffuse gastric cancer.
What are some of the classification systems for gastric adenocarcinoma?
Gastric cancers are broadly classified into intestinal type tumors, which are arising from the gastric mucosa, and diffuse type tumors, which arise from the lamina propria and are associated with an invasive growth pattern and rapid spread. With the evolution of development of identification of various tumor markers, these days a lot of additional IHC markers are used to reclassify these tumors, and we will go into that in a little bit.
So how would you work up this patient and make a diagnosis?
The workup starts with a complete history, physical examination, and some basic lab workup, including CBC, CMP. And the gold standard would be an EGD with a biopsy to confirm the diagnosis. And it's important that the endoscopists know that they can perform an endoscopic ultrasound if the lesion looks like malignancy or if it has been biopsied elsewhere for completing the staging and workup. Most importantly, you're going to get information about the T stage and end stage from the EUS. There are additional tumor markers that can be tested on the biopsy specimen, which I mentioned earlier, including HER2 expression, PD-1, EBV, and microsatellite instability. And to complete their staging workup, and you have to get a CT scan of chest, abdomen, and pelvis to rule out any metastatic disease. Ideally, it should be performed with IV and oral contrast. And in certain situations, we obtain a PET scan as well to complete the staging.
When would you consider a diagnostic laparoscopy?
That's a very important question, and it's actually a staging test that we use largely in gastric cancer because of its ability to have localized peritoneal metastases. The diagnostic laparoscopy and peritoneal cytology is something we perform for patients who have a T2 or N-positive disease to rule out any occult peritoneal disease.
What are the treatment options for gastric cancer?
This area has evolved a lot over the past decade, and not that it's relevant too much for surgeons, but it's important to know that there is an early stage tumors, for example, T1A, which are diagnosed with endoscopic ultrasound. The management is evolving, and a lot of times we are using endoscopic submucosal dissection for those patients if that's technically feasible and your GI team is comfortable with that. Most of those discussions happen in a multidisciplinary manner, and several centers have published their data on that in the US, where it's recommended for patients with early stage tumor. And in these cases, you can omit the diagnostic laparoscopy. But for resectable patients, the primary goal of surgery is to accomplish a complete resection with a negative margin. And the number, I think, in our book says around 4 centimeters. However, that has been evolving. It depends a lot on the location of the tumor, whether the patient would need a subtotal gastrectomy or total gastrectomy, but it has to be combined with the D1 or modified D2 lymphadenectomy.
Can you tell me more about the lymphadenectomy and how many lymph nodes should be sampled?
That's a very good question. D1 lymphadenectomy, when that term is used, it typically refers to perigastric lymph nodes. And when you make it D2, it's perigastric lymph nodes, including the celiac, left gastric, common hepatic, and splenic artery lymph nodes. The recommended number for lymph nodes is around 16 or more. And these days, we have seen that sampling those lymph nodes is actually very important to determine planning regarding their adjuvant treatment options that the patients would receive. So these days, a lot of gastric cancer procedures are performed using minimally invasive approaches. Several randomized trials have demonstrated equivalent oncologic outcomes and rapid recovery with minimally invasive surgeries that are performed for gastric cancer.
What are some key points regarding systemic therapy?
Systemic therapy has evolved a lot in this area, and in the setting of locally advanced or resectable gastric cancer, especially tumors at the GE junction, perioperative chemotherapies approach is the standard of care, especially for patients with good performance status. It is also preferred approach for localized resectable disease if possible. But there are several chemotherapy regimens that can be used. The most common ones are either FLOT or FOLFOX, and the choice of the chemotherapeutic agent depends on the patient's performance status and our suspicion and location of the tumor. Based on the final pathology, sometimes we offer adjuvant chemotherapy to patients as well, because it has been shown that combining surgery with adjuvant chemo is still much superior than surgery alone.
Are there newer treatment options that are being used in gastric cancer?
This is a very interesting area, and it's actually evolving a lot, and there are several clinical trials which will be very critical in answering this question. But as I mentioned earlier, there are certain biomarkers that are specific to the tumor that we are testing patients for, which open the doors to newer therapies. For example, if the tumor expresses HER2, patients become candidates for trastuzumab. Immunotherapy can become an option if the patient's tumor expresses PD-1, if there is expression of EBV or MSI for MSI high tumors.
When should you consider palliative therapy?
Yeah, it's a very important and relevant question. Despite all the improvements that we are seeing in gastric cancer, we still unfortunately have a lot of patients who present at a metastatic stage or disease where they cannot undergo any curative treatment options. So patients who present with peritoneal disease, with hepatic or distant nodal metastases, or have very poor prognostic factors overall, are the ones who should be considered for palliative approaches. And these days, a lot of those procedures can be done endoscopically. But it's important to remember that there's a subset of patients with good performance status where even palliative surgical resection can be considered to improve their symptoms and quality of life.
Thank you, Dr. Panni, so much for being with us today. We got through a ton of great information about the stomach. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of the stomach chapter can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.